Good morning, ladies and gentlemen. Thank you very much, Georgianne. So in the next 45 minutes or so, we'll talk about CT and the evaluation of thromboembolic disease. And we'll try to explain what the current literature is and why this supports the use of CT as the prime modality of choice for the investigation of pulmonary embolism. Then I'll try and highlight some areas where we can improve our technique. And I'll spend the bulk of our time talking about acute pulmonary embolism and pitfalls in its interpretation. Finally, I'll spend a little bit of time talking about the much less common entity of chronic thromboembolic disease, and at the end, spend a little bit of time talking about current and future developments in imaging of thromboembolism. So when faced with a patient who possibly has evidence of pulmonary embolism, we have several imaging modalities at our disposal. We know at one end of the spectrum that chest radiographs are relatively insensitive and nonspecific for the diagnosis. And at the other end of the spectrum, although there are rapid advances in MRI technique, this is probably still not ready for the majority of patients. So we're left with three main modalities: ventilation perfusion imaging, classical pulmonary angiography, and CT pulmonary angiography in both its single and multi-detector incarnations. So how do these tests fare against each other? Well, the first thing to note about ventilation perfusion imaging is that, as we know from the PIOPED studies, a large proportion of these studies are indeterminate. And when compared to CT pulmonary angiography, even in the single detector mode, we can see that in this representative study, there are significant advantages in sensitivity, specificity, positive and negative predictive value with CT pulmonary angiography, and also significant improvement of inter-observer agreement. Of course, CT offers us the additional advantage of making an alternative diagnosis when the cause of the patient's symptoms is not a pulmonary embolism, as in this patient who presented with a small cell lung cancer but had a PE study nonetheless. We've had CT pulmonary angiography in single detector form for at least 10 years now, and meta-analyses of the specificity and sensitivity suggest that this is in the high 80 or 90 percentile range, especially for the detection of main lobar or segmental pulmonary emboli. But it is this variable and relatively low detection rate for sub-segmental pulmonary emboli that led two prominent thoracic physician bodies to suggest that CT alone was an insufficient test for the exclusion of pulmonary embolism. And what test did they suggest as an ancillary test? Well, they suggested classical angiography. Well, we know that classical angiography is a good test with a small rate of significant complications. But the problem is that CT angiography and angiography itself suffer from the same limitations, and that is the interpretation of subsegmental vessels. Two-reader inter-observer agreement is only near 50% for classical angiography at the subsegmental level. And if you're fortunate or unfortunate enough to have three angiographers in your practice, well, the agreement between these people is as good as three people trying to guess what a coin flip is. It really is extremely low at 16%. So what about multi-detector CT? Well, of course, we know that with isotropic volume sets resulting from increased speed and reduced collimation of scanning, we should be able to see the smaller vessels much better and hopefully, therefore, detect pulmonary emboli. And of course, we have the additional advantage of advanced imaging processing, such as multiple maximum intensity projections and multiplanar reconstructions. So these are two different patients trying to illustrate the advantage of multi-detector CT. Both appear to have a possible pulmonary embolus in a parallel-oriented vessel. However, as we reconstruct the data set at ever thinner collimations, we can see that only the image on the left of the screen reflects a true positive finding, the image on the right reflecting a false positive finding. So CT not only increases our detection of small subsegmental pulmonary emboli, but also reduces the rate of false positives. And this has now been demonstrated in several studies that show that as we reduce the reconstruction algorithm, reduce the reconstruction interval and thickness from 3 to 1.25 millimeters, we increase our sensitivity. This is also demonstrated in a separate study demonstrating increased subsegmental detection by 40%. And of course, as we reduce our thickness, we also improve our inter-observer agreement. Well, I think we now need to discuss a little bit about the isolated subsegmental pulmonary embolism. And this is a particularly important subject because this is the area in which our clinical colleagues are concerned that single detector CT may be missing pulmonary emboli. No one is really concerned about missing subsegmental pulmonary emboli in a patient in whom we've already identified lobar segmental pulmonary emboli, because this is not going to change clinical management. So how common are these isolated subsegmental pulmonary emboli? Well, we don't really know. The incidence has been quoted as low as 6% or as high as 36%. And we also know that these findings may be transiently normal as part of the normal filtration system of the lung parenchyma to prevent systemic embolization. As in this particular patient who had a small pulmonary embolus confirmed on serial images that resolved with no treatment 48 hours later. We don't know whether there's actually a benefit in treating these patients, and that is a hotly contested subject currently. We don't know also if these progress to chronic thromboembolic disease, and clearly our decision to treat these patients is going to depend on what the individual cardiovascular reserve of a patient is and whether we believe that there is a source of future thromboembolic events. Well, what about if you have single detector CT? Can you still reliably exclude pulmonary thromboembolic disease? Well, this study by one of the pioneers of pulmonary CT angiography addresses this issue. A group of 125 patients were consecutively evaluated with single detector CT, and in this group, an optimum evaluation of the subsegmental pulmonary emboli was only possible in about 13% of patients. The subsequent group of patients were evaluated with multi-detector CT, and as expected, there was a higher rate of optimum evaluation of the subsegmental pulmonary vessels. In this particular study, patients who had a negative CT were not treated, but followed up at 3 months. And we can see that the negative predictive value in both groups was precisely the same. So what does this show? It shows that in the group of single detector scanners, we are probably missing some small subsegmental pulmonary isolated emboli. However, non-treatment of these is of no clinical significance. So it seemed like we had reached a point where we had proven that multi-detector CT had addressed the limitations of single detector CT. Unfortunately, we have a study that is in the works that is due to be published. It's still in the process of being revised several times because of the problems in the design of this study. And this is the PIOPED II study. It's a very large study evaluating the utility of multi-detector CT in the evaluation of pulmonary embolism. All patients had a CT angiogram and combined with a CT venogram. And most importantly in this study, a patient was considered to have a pulmonary embolism not only if they had a high probability VQ scan, not only if they had a positive classical pulmonary angiogram, but also if they had a peripheral ultrasound Doppler of the lower limbs that was positive, some symptoms in the chest, and non-diagnostic other tests. Now, with this very flawed gold standard, it's not surprising that the sensitivity and positive predictive value of CT is relatively low and improves only marginally by incorporation of CT venography. What's more, when we look at the sensitivity of CT at the subsegmental level, this is comparable to the single detector era. And this is presumably because these patients were evaluated in comparison to classical pulmonary angiography. Furthermore, in the small fraction of patients that had a high clinical suspicion of pulmonary embolism but a negative CT, in this study, 39% had pulmonary embolism. So this was a very troubling study. There were some additional conclusions from this study in preliminary form that have been released at meetings, and they suggest that CT alone is unreliable and that its variability in accuracy is as low as 58 to 96%. They suggest that the likelihood ratio of a positive study is high, but that of a negative study is insignificant, particularly because of this group of patients who have high clinical suspicion but a negative CT that mandate further testing. The authors are also suggesting that CT venography should accompany CT angiography despite the dose implications. Well, in addition to the limitations I've already mentioned, there are a few other limitations that have become apparent in clinical meetings, and that is that there is insufficient data to compare 4-slice scanners versus 16-slice scanners. Most of these studies were performed on 4-slice scanners. All the studies were performed without any bolus tracking. There was no correlation with D-dimer. There were no sick patients in this group. They were all outpatients. And there was really no evaluation of the possible false positives of pulmonary angiography or ventilation perfusion imaging, and no assessment of the additional value that CT offers in the evaluation of a patient. So when this study is eventually formally published, it behooves us all to look at the details of the study, because this is going to be a point of discussion for many years to come between clinicians and radiologists as to the limitations and value of multi-detector CT. Okay, I'd now like to move on to how we can optimize our technique. Now, on this complicated chart, which is included in your handout, I've tried to highlight the different the different techniques we use according to the different scanner hardware that we have. In summary, we try to use the thinnest collimation possible that we can achieve coverage of the area of interest. If you have a single detector scanner, you might have to restrict that to the central vasculature. If you have a multi-detector scanner, you can cover the entire chest. We always try to use the thinnest collimation possible, following an injection of a slightly higher volume of contrast at a slightly higher flow rate than our conventional studies. We also perform CT pulmonary angiography in pregnancy. In our particular department, we reduce the radiation dose exposure and we limit the examination to just above the aortic arch to the level of the xiphoid process. We never perform CT venography in these patients for obvious reasons. Now, my personal preference is always to perform a chest radiograph in a pregnant patient before going on to CT pulmonary angiography, though this is not universally adopted. Now, the reason I believe that is that unless the patient is an extremis, I don't believe that displacement of pulmonary arterial vasculature is an appropriate way to diagnose a pneumothorax in a pregnant patient, and then having to try to explain to this patient why she's been exposed to several hundred times the radiation dose of a simple chest X-ray. What about dose reduction modules? Well, on the Siemens scanners, for example, there's a product called CareDose. There are equivalent features on other scanners. And these try to reduce the dose when scanning in the anteroposterior plane and increase the dose when scanning through the shoulders to increase penetration of the patient. However, when the tube is operating at the limits of its ability, as it is in most CT angiogram studies, this artificial reduction in the AP projection can materially degrade image quality. And we have found that the trade-off of a slightly higher dose is very beneficial in improving our image quality on CT studies. Using a saline flush, you can significantly reduce the volume of contrast that you wish to deliver and reduce artifacts in the central systemic venous vasculature. If you have a single detector scanner or an older generation multi-detector scanner, cordocranial imaging may reduce motion artifact at the end of the breath hold. But for the newer generation multi-detector scanners, it remains much simpler to perform craniocaudal imaging throughout the examination. And finally, probably the most critical element of technique is the timing of image acquisition. I think we've moved away from best guess approaches of 15 to 20 seconds and also timing runs of small test injections to more automated systems such as CareBolus or SmartPrep, where we can maintain a region of interest over the pulmonary artery during the early phase of injection and trigger the examination at a particular threshold. Our particular preference for this is to trigger at about 130 Hounsfield units. What about our image interpretation? Well, we reconstruct all our images on a smooth algorithm, and it is essential that we perform cine viewing of these examinations on a workstation or PACS system. I think that if you have to occasionally interpret a hard copy examination, you really are susceptible to making quite gross errors in interpretation. This patient looks like they have beautiful opacification of the pulmonary arteries, but if we adjust the window level and width, we can see that this conceals a relatively large central pulmonary embolus. We really cannot be prescriptive about the window level and width. This will depend upon the contrast opacification and the size of the vessel that you're trying to evaluate, and you have to dynamically alter these levels as you evaluate the examination. Multiplanar reconstructions are obviously an added advantage of multi-detector imaging. Here, a patient who has a pulmonary embolism with an infarct demonstrated on the same coronal reconstruction. For the most part, I find that the routine use of these is not helpful in my daily practice. Some people have found that using sliding maximum intensity projections, either in an axial plane or an off-axial plane, may be helpful as an initial screening, but I really don't think that that detracts from having to still review the original source data, and so I find this to be an additional unnecessary step. Some authors have also suggested going a step further and doing rotating multiplanar reconstructions to elongate out vessels, but really I think apart from a bit of vertigo, this doesn't really help in the interpretation. You know, I did this slide last year and it took me a whole day to do, and all the P's are visible on the very first slide. So where do I think the multiplanar reconstructions do help? I think they help with small pulmonary emboli. So this is a patient who we imaged at our routine 2 mm collimation, and even with the hint of the image below here, it is very difficult to appreciate the pulmonary embolism that is present in a small vessel in the left lower lobe. Even when using the 0.8 mm images, this small pulmonary embolism is very difficult to identify. But using a stack of thin MIPS, this abnormality does really stick out, and then once you identify it clearly, you can go on and perform more dedicated reconstructions. Okay, so let's move on now to the findings of acute pulmonary thromboembolic disease. Most of us are familiar with the classical findings of a large central filling defect, usually with acute margins to the vessel wall. These can be serpiginous in nature, and either large emboli may expand the vessel, or smaller emboli may expand vessels due to reactive vasodilatation around an embolus. When we start to see vessel cutoff or non-filling of vessels, as in this case here, we can be less specific that this is an acute thromboembolic event because there is overlap now with chronic thromboembolic disease. Looking at the lung parenchyma, we're familiar with areas of hemorrhage which may be triangular in appearance. These may progress on to areas of infarction that with time may progress and resolve to a scar. This is about 6 weeks after the initial event. Most commonly, we'll see areas of atelectasis, and the atelectasis may indeed conceal pulmonary embolic disease. Generally speaking, effusions are a very common finding occurring in about a third of patients, and these can be multiloculated or hemorrhagic in nature and respond purely to anticoagulation alone. We generally don't see mosaic attenuation, but occasionally we'll see the CT equivalent of Westermarck sign, the pulmonary vascularity of an entire lung being significantly reduced with small thready vessels. Now, knowledge of these signs can be very important. This is a patient who had HIV, who had complex pleuroparenchymal cavitary disease, who was not responding to intravenous broad-spectrum antibiotics. At 5 days, he had pigtail catheter insertion into these cavities, and it was only several days later on an initial contrast-enhanced study and then a dedicated examination that it was clear that these findings were due to cavitary thromboembolic disease, and the patient recovered with anticoagulation alone. A question that often arises is whether a patient has a massive pulmonary embolism, such as in this particular case where I think this is the largest pulmonary embolism I've ever seen, but the term massive pulmonary embolism has a particular connotation that cannot be answered from these images alone. Many people confuse the term massive pulmonary embolism with that of saddle embolus, usually a central bridging pulmonary embolus, but the two are not synonymous. Massive pulmonary embolism is characterized by a patient who has pulmonary embolism with echocardiographically proven right ventricular dysfunction and systemic hypotension. Those patients with submassive PE are characterized as having a PE and right ventricular dysfunction but no hypotension, and low-risk PE are the patients who just have a pulmonary embolus. And the importance of this classification is that mortality is directly related to this classification system. And patients with massive PE now are best treated with thrombolysis rather than anticoagulation. Patients with low-risk pulmonary embolism are best treated with anticoagulation, and there is some remaining contentious argument about the best treatment of submassive pulmonary embolism. So how do radiologists fit into this pattern? Well, this is a patient who presented with hypotension and central pulmonary emboli. He was treated with thrombolysis as opposed to anticoagulation and responded very rapidly over the course of 10 days with rapid resolution of both radiographic findings but also hemodynamic findings. And this has led people to try to investigate signs that reflect right ventricular dysfunction. And we have several features now that reflect right heart strain, and these have been correlated with morbidity and mortality in patients with acute pulmonary embolism. We can look at the size of the main pulmonary artery and look for an enlargement above 3.5 centimeters or above 3 centimeters if this exceeds the size of the aorta at the same level. But an even better sign is dilatation of the right atrium and right ventricle to a size greater than the left-sided chambers. This is a feature that is seen in a large proportion of patients who have a fatal outcome with pulmonary embolism. We can also look at deviation of the atrial septum and straightening or reversal of the interventricular septum. Now, this finding is less reliable. There's a lot more variation in people's interpretation of this. So I've tried to demonstrate it with two cases. This is a patient who does not have evidence of acute cardiac strain, and this patient does. I've performed multiplanar reconstructions through these two cardiac chambers, and we can see that the patient who has cardiac strain not only has dilatation of the right ventricle, but also straightening of this interventricular septum. Now, I performed this multiplanar reconstruction purely for illustration purposes, but there are emerging studies that suggest that using volumetric analysis of right cardiac chamber size may be a very useful predictor. This is a patient who had a saddle embolus with features of massive pulmonary embolism. And just to show that these features are reversible, 6 weeks later, there is a reversal to a normal, slightly convex interventricular septum. We do sometimes see reflux of contrast into the IVC or in the hepatic veins. It is not abnormal to have a small amount of contrast reflux into the IVC, but if the IVC and hepatic veins are significantly opacified and dilated, one should consider the possibility of right cardiac strain. If we see filling defects in the right atrium or in the right ventricle, these are a very, very poor prognostic factor for patients. So coming back to my original question as to whether this patient had a massive pulmonary embolism, we can see that when we see the cardiac chamber images, there's reversal of the interventricular septum in this particular case, and this patient died approximately 2 hours after the acquisition of the examination, despite therapy. Okay, so now let's talk about a few pitfalls in the interpretation of CT. I think that the most common cause for a misinterpreted pulmonary embolism study is when we try to do too much. When the contrast opacification is inadequate, you really cannot interpret small pulmonary vessels. So state that in your report. There is no point in trying to go further and further out when the contrast just precludes that. Clearly, there are other artifacts that we may encompass, and those include motion artifacts, which may be due to respiration or cardiac pulsation, and these are usually best exhibited on the pulmonary images. You may see streak artifacts from metal, or maybe we have noise from contrast or from image noise. Most of us are also familiar with most of the common anatomical pitfalls. Usually lymphatic tissue at the right hilum may cause some initial confusion, but if we can see that the pulmonary artery descends below this, then we are confident there is no evidence of pulmonary embolism. And if need be, we can perform a multiplanar reconstruction demonstrating a normal pulmonary artery with lymphatic tissue above and below. Vessel branch points may be a problem, especially if there's a little bit of motion on the study. And bronchial impaction, which may mimic a pulmonary artery, may be avoided by reviewing the pulmonary windows at the same level on this particular patient. As I've already suggested, atelectasis and consolidation is a very common feature and may conceal pulmonary embolic disease. I'd like to spend a bit of time, though, on a more recent pitfall that has been described that is affecting people more with multi-detector scanners. This particular patient has multiple potential filling defects within pulmonary arteries in the upper lobes bilaterally. When we review the more central images, we can see that the main pulmonary artery has relatively poor contrast opacification. So maybe we are just a little bit late with our study or a little bit early. But we can see in this particular case that there is good opacification of the pulmonary arteries distally, but also good opacification of the pulmonary outflow tract and right ventricular chambers proximally. So really, this does not go for either a too late study or a too early study, and really reflects a different finding altogether, and that is a physiological artifact called contrast interruption. This artifact tends to occur in young patients who take a very vigorous inspiration prior to the examination, and a bolus of unopacified blood may be sucked in from the IVC into the right atrium, and then travel as a bolus through the pulmonary arterial circulation. And if we happen to image the patient at this particular point, this may mimic a pulmonary embolism. The keys to differentiating this from pulmonary embolism is that it's usually a bilateral finding affecting both sides of the pulmonary vasculature. It's relatively ill-defined, and we see good opacification both distally and proximal to this apparent filling defect. Now, last year I was asked by many people how you can avoid this artifact in patients, and I think the recommendations that we have are that patients should take a slightly smaller breath in, they should take a more gradual inspiration, And recently at the RSNA, I saw a paper presented on patients who had had this artifact on an initial study who was scanned during expiration as a method of evaluating the patients, and they had a very good success rate in a small number of patients. So that may be something that we'll be trying in the future for patients who are suffering from this artifact on their original examination. Okay, so we've discussed some PE pitfall interpretation, some errors in interpretation due to pitfalls, but where do I think that we make more errors than these common pitfalls that are described in most of the literature? Clearly, the more subsegmental pulmonary vessels we have to evaluate, the more likely we are to miss a small subsegmental pulmonary embolism. Hopefully this will be isolated and of no clinical impact. We're going to make mistakes when there are pitfalls present and pulmonary emboli. In this particular patient, we can see that there are hilar nodes on the right side and a pulmonary embolus on the opposite side. In this particular patient, it's more complicated. There are right hilar nodes. There's a mass of the left hilum invading the pulmonary artery, but also a pulmonary embolus. So just finding a pitfall doesn't mean that there cannot also be a pulmonary embolism. In this particular patient, a very similar example, we have what we think is lymphoid tissue at the right hilum, but there's also possibly a filling defect. And this is an area where multiplanar reconstructions can be very useful. Here's the lymphoid tissue, and here's a pulmonary embolus within the main pulmonary artery. Occasionally, we see isolated upper lobe pulmonary artery emboli, and these are common in the truncus anterior, and this vessel is very difficult to interpret because it passes behind the superior vena cava, which often contains a lot of dense contrast. And therefore, this is another area where I think that performing multiplanar reconstructions can help to aid our diagnostic confidence in making a diagnosis of an upper lobe pulmonary embolism. On other occasions, we may diagnose a pulmonary embolism and be very pleased with ourselves. This is a relatively obvious example, but we have to be careful to always check and see if there's a potential source, as in this particular patient, where there is a central line clot that was the source for this pulmonary embolism. Another area where we may miss pulmonary emboli is when we're not originally looking for them. This was a staging CT scan performed for malignancy, and on a single 5mm image, there's a small potential filling defect in a pulmonary artery. Now, the advantage of multi-detector CT is, of course, that we can reconstruct the data set at a thinner collimation, and these are overlapping sub-millimeter images demonstrating a branching pulmonary artery embolus. And to the consternation of our clinical colleagues, who now do not know whether to treat this patient or not, we can demonstrate this on multiplanar reconstructions also. I would not advocate the use of non-contrast CT to detect pulmonary emboli, but occasionally you may see areas of hypo or hyperdensity depending on the extent that the clot has been there for and the time period that it's been there for. In this particular case, we can see that there are filling defects that are appreciable even on the non-contrast study. Finally, not everything that's in the pulmonary artery is definitively an embolus. In this particular case, we can see a filling defect within the pulmonary artery, but there's clearly a soft tissue mass which extends into this region, and this is a lung carcinoma that invades the main pulmonary artery. Now, this is a relatively simple example, but unfortunately, occasionally you're presented with a case like this, and this is a totally intrapulmonary hemangiosarcoma, and unfortunately, this is a case where you really cannot make the diagnosis from the start unless for some reason you were suspicious and performed a MRI to evaluate enhancement within the embolic material. Okay, in the last few minutes, we're going to talk about chronic pulmonary thromboembolism and current developments. Now, chronic PE is an entirely different subset of patients from those patients presenting with acute pulmonary embolism. And these patients usually present with the symptoms of pulmonary arterial hypertension, that is to say, fatigue and dyspnea. And usually, but not always in these patients, they do not recall the initial event of thromboembolic disease, be that a PE or a DVT. And the most important thing that I can stress for these patients is that they do not reflect recurrent pulmonary embolism. What leads one patient to have a complete anatomic and physiologic recovery from a pulmonary embolism and another patient to have an incomplete recovery is unknown. Some of these patients, a small minority, have anticardiolipin or antiphospholipid antibodies, but the majority do not. This is probably some form of abnormal physiological recovery from an embolism that occurs in less than 2 or 3% of patients, results in formation of small webs and strictures and local cytokine release that results in a remodeling of the pulmonary arteries and local plexogenic changes which result in situ recurrent thrombosis thereafter. The findings that we see in these patients are different to those of acute thromboembolic disease. The thrombus is usually eccentric and may lie along the edges of the vessel rather than the central acute thromboembolic disease. We may see webs in the vessels that make the appearance here of a kind of trefoil pulmonary artery, or there may be indentation from bands along the lateral margin of the pulmonary arteries. We may see expanded and irregular vessels, but also small outpouchings from the side of vessels, which are features of the chronic thromboembolic disease. Small irregular vessels may be present in areas of prior infarction. These little corkscrew vessels are relatively characteristic of chronic thromboembolic disease. When you have an area of prior clot adherent to the wall of the pulmonary artery, with time you may see recanalization within that thromboembolic disease. More common than in acute thromboembolic disease, we see areas of abrupt cutoff of the pulmonary vasculature in this patient who obviously also has quite prominent mosaic attenuation of the lung parenchyma. Now, key to the determination of chronic thromboembolic disease is the presence of pulmonary arterial hypertension, and this has a quite significant overlap with the features of right cardiac strain that I demonstrated to you earlier in patients who have massive pulmonary embolism. But the key differentiation is the chronicity of the findings. So in addition to enlargement of the main pulmonary artery, as we see in this particular case, we start to see features such as thickening of the free wall of the right ventricle, a feature of right ventricular hypertrophy. And in addition to the dilatation of the right-sided cardiac chambers, we start to see thickening of structures such as the moderator band. And we may get this kind of dirty appearance of the inferior aspect of the right ventricle due to thickening of the trabeculae that are present within the RV. Due to the chronic reduction in pulmonary blood flow, we start to see hypertrophy of the bronchial arteries, and these are most prominent in the subcarinal region. Clearly in the lung parenchyma, as I've already demonstrated, we can see mosaic lung attenuation. There may be areas of infarction or scar formation, and in areas of hypoperfusion, we occasionally see appearances that mimic bronchiectasis due to reactive bronchial dilatation. Now, it is worth bearing in mind that there is a potential cure for patients who have chronic thromboembolic disease. The procedure is termed pulmonary thromboendarterectomy. They resect both the thrombus and the intima of the pulmonary artery. And although this was a procedure that used to fill patients and surgeons with dread with a very high mortality in the early 70s, this procedure, due to advances in surgical technique and pre-selection of patients, has become a relatively safe procedure. And we must bear in mind that this affects a permanent cure of pulmonary arterial hypertension. Those patients who survive a year out of the procedure have zero mortality thereafter. Now, which patients can we advise or potentially suggest may benefit from this procedure? Well, the best surgical results are for large central vessels, and the results are generally very poor for patients who have isolated peripheral disease, small spirally vessels, or isolated mosaic attenuation. And also in this particular subgroup, the prognosis is worse in patients who have comorbid pathologies such as COPD or interstitial pulmonary fibrosis. This is a patient who I've demonstrated to you earlier on already, who had his features of chronic thromboembolic disease originally and underwent a pulmonary thromboendarterectomy. You can see that the pulmonary artery is still enlarged, but all the clot that was previously identified has left. We can see that the webs and the strictures that were present before are also resolved, and an almost normal appearance of these pulmonary arteries now. The main pulmonary artery has reduced in size, and the features of right cardiac dilatation have also significantly improved. And some of the most fascinating features are in the lung parenchyma. This is the mosaic attenuation that was present previously, and now we can see almost a reversal of this pattern as perfusion to the previously hypoperfused areas increases, and we start to get ground glass and small reticular changes occurring in the areas that are now reperfused. Okay, so in the final portion of this talk, I'd like to talk to you about a few current and future developments in the evaluation of pulmonary thromboembolism. Well, from a medical perspective, we're moving towards improved pre-selection of patients who will be presenting for evaluation with imaging modalities. Now, we're already aware of the possible impact of D-dimer evaluation, but our clinical colleagues are looking towards a whole spectrum of different biomarkers, such as subtypes of the troponins, creatine kinase, but also brain natriuretic peptide and myoglobins, because these may be used as a panel to help differentiate patients who have cardiac disease who require a different sort of workup from those patients who have pulmonary thromboembolic disease. And we already are aware that D-dimers are impacting our workflow on a daily basis, and there are many studies now demonstrating that the very high negative predictive value of D-dimer assays, either at the 1,000 microgram per liter level or the 500 microgram per liter level, can significantly reduce the number of negative CT studies that we perform. However, I think it's very important to bear in mind some of the caveats that come along with using a D-dimer test. There are several false positive etiologies and several false negative etiologies, and these clearly are the most important. Many studies, knowing that these patients have a high risk of a false negative, do not incorporate these patients in studies of D-dimers. So it really is important to look at the D-dimer literature and see whether the studies reflect all patients presenting to an emergency department or pre-selected patients. I think if you look at this subgroup of patients, you can see that patients who are too early in their evaluation or too late, the elderly and anticoagulant, patients who are on anticoagulation, may have a falsely negative D-dimer test. Now, I'm not suggesting that the D-dimer test is not a good test. I think it's an excellent test. But I think we have to bear this in mind. And if a patient has a negative D-dimer, but the clinician still thinks that there is possibility of pulmonary embolism, we're duty-bound to do this investigation. On the false positive side, I think the most notable one is pregnancy. I often hear the argument that patients who are pregnant, we don't do D-dimers because they're not helpful. Well, pregnancy does not cause a false negative D-dimer. 75% of patients in the first trimester will have a normal D-dimer. 50% of patients in the second trimester will have a normal D-dimer. We may be able to reduce the number of patients who are pregnant and having CT pulmonary angiogram studies by selectively using D-dimers in these patients as well. What about the imaging future? Well, there have been many studies now that are suggesting that possibly we should be grading or classifying the quantity of PE. And really, this is still a study in evolution. There are many studies that suggest that trying to identify a CT-PE index may be a useful guide for thrombolysis, but there really is no strong evidence yet that quantifying the amount of clot is an independent prognostic factor for these patients, independent of right cardiac strain or their overall physiologic status at that time. We have a lot of questions as to whether we should follow up PEs. We don't really know how long PEs should last or how quickly they resolve. And this is still an issue which is probably going to be looked at more in the future. And clearly, with the advances in MRI technology and 64 detector imaging, we're going to be looking to better and more improved ways of looking at pulmonary embolism. The PIOPED III study, I already mentioned to you that the PIOPED II study is not fully published yet. The PIOPED III study is already initiating, comparing MRI to 64 detector imaging. Well, what about MRI? Well, we've moved from the kind of earlier vibe sequences and flash sequences to parallel processing and high field strength. And gradually our image quality is improving, but I think we've still got a long way to go with MRI. How about 64 detector imaging? Well, I think our preliminary experience with 64 detector imaging is that we actually have a slightly higher rate of examinations that are slightly suboptimal. And that's because the scanner is so fast that if the timing of the contrast is not perfect or the patient breathes slightly, that degrades a large number of images. And so we're actually probably finding that some of our studies performed on the 16 detector scanner are as good or better sometimes than the 64 detector scanner imaging. There are clearly, though, some advantages of 64 detector imaging, and virtual angioscopy may be an advantage. This is going to be of particular importance in patients who have chronic thromboembolic disease because it helps in surgical planning. The use of 64 detector scanners also heralds the possibility of performing perfusion imaging on the lung parenchyma. These are some images acquired in a pig model. The pig is scanned during a single breath hold very early on in the arterial phase, and then later on during the pulmonary arterial phase. The two images can be subtracted, and then not only do we have a direct evaluation of the pulmonary arterial vasculature, but we also have a perfusion map of the lung parenchyma. And this study that was originally done in a porcine model has now been translated into human models, and we're already getting the first images of human perfusion imaging combined with CT pulmonary angiography. Finally, as we move towards thinner and thinner detectors and more images that we have to interpret in our daily practice, it's clear that computer-aided diagnosis is going to be of great assistance to us in the future. And this model on the left is a 3D rendition of the pulmonary arterial vasculature. It's freely rotatable. The objective is to demonstrate areas of higher concern that may then be clicked on, and we go to a orthogonal projection of CT images through that region that may help us in our determination of pulmonary embolism. There are also some newer CTP CAD tools that help to identify small pulmonary emboli in the periphery of the lung parenchyma. And these techniques hold hope for the future, but are still probably in their infancy. Hopefully, by the time we meet next year, I'll be able to offer you some more information on how CAD is going and hopefully whether it will be reducing the impact on our daily workflow.